continue with Dr. Mourtarakos with the title of aortic valve neohospitalization and the management of complex aortic valve pathology in children.
Greetings, dear Professor Kalangos, and greetings, dear future Professor Dr. Chatelain and Dr. Petropoulos. We're grateful for the possibility to present our experience in aortic valve neohospitalization in management of complex aortic valve in pediatric patients. We are also grateful to Mr. Kalangos for his humanitarian help to Ukraine and his general help to our Heart Institute. Management of the surgical aortic valve replacement and pathology in children is different from that in adults, as one must consider. It is placed with the morphophysiological characteristic of child organism, with the small size of anatomical structures and the need to consider the growth potential, which can, in follow-up, impact the elevated risk of the development of a prosthesis-patient mismatch. This limits the surgical aortic valve replacement with biological or mechanical prosthesis, especially as the child organism has more severe impact on biological materials that are not native. As such, the long-term results of current valve-preserving techniques like aortic valve commissurotomy or leaflet shaving has not shown sufficient results. On the other hand, ROS procedure is, as Professor Kalangos told, and it is true, it is the best choice, although ROS procedure is a hard teamwork, and not every center has such surgeons that are able or are ready to perform such operation. As such, aortic valve neohospitalization, although being controversial, can be considered in patients with feasible anatomy. The principle and the unique characteristic of aortic valve is that due to its fan-shaped structure, it has less stress on leaflets. It helps create a larger effective orifice area for patients, decreasing the incidence of prosthesis-patient mismatch, and as child's pericardium is its own tissue, it has no immune rejection from the host organism. Currently, there are more than 8,000 AV neo procedures performed worldwide. Heart Institute is one of the leading 10 clinics in the world after the number of procedures performed. In the current literature, there are only two significant meta-analyses of AV neo in adult patients. One coming from Greece, with 22 studies including 1,900 patients, which showed 5-year freedom from reoperation of 96.5%. And another coming from United Kingdom with a study comparing different types of aortic valve replacement, also including ROS procedure. And from the statistics of this paper, we can see that AV neo is the second procedure considering youngest mean age of patients. Publications on the AV neo in children are very scarce. There are only two meta-analyses, one by Indian and one by German colleagues, dated by 2023 and 2026 respectively. All of them present immediate and short-term results that are good in patients, although they do not include mid-term and long-term follow-up. Our patient cohort consisted of 10 consecutive patients, 6 of which had bicuspid aortic valve, although it was trisinuate, because bisinuate aortic valve is not suitable for Rozaki technique in its basic type. 4 patients had a tricuspid aortic valve, and 5 patients, half our cohort, had the previous interventions. The operative characteristics are as following. Ozaki technique had been chosen in these cases as feasible procedure, and even though 5 patients had previous surgeries, and 3 of which were open heart surgeries, we still were able to use glutaraldehyde treated autopericardium. Although we used 2 two xenopericardials in patients due to inability to use the patient's pericardium. We had a follow-up of 73 months, of which, as shown as long-term results, all of our patients had gone through reoperations. Although, as we can see, aortic annulus had grown and the Ozaki valve was suitable for these patients. We had 7 reoperations, 5 done in our clinic and 2 done in other international clinics. In one case it was ROS procedure, one case it was patient already suitable for surgical aortic valve replacement with mechanical prosthesis, and 5 patients were normal size mechanical prosthesis. Here you can see the operative characteristics of reoperations. The ventilation time was 6 hours, suitable for these patients, and we had no mortality in general. Seeing the follow-up, we had 100% survival of our patients with aortic valve neocuspidization and 22% freedom of reoperation during our follow-up. In conclusion, we would like to say that aortic valve neocuspidization will never be a golden standard for aortic valve replacement in, especially in the pediatric patients. Although it may be a feasible option if ROS procedure is not available, either due to limitations of surgical team or the limitations of absence of bank for homografts or inability to do ROS procedure in general. And the degeneration of the leaflets tissue is rapid in children, and although 73 months is quite a good follow-up and it gives time for further operations, it must be considered very closely. In our cases, all patients and all adults of their patients were informed about all the procedures that can be performed in such cases, and it was the choice of the adults to perform AV-neo. And it would be a pity for us to not include our results, even though they're not the best. Thank you very much for your attention.
Thank you. Thank you very much. It's really a very good presentation and an honest presentation, because I have also some friends who started doing, Ozaki procedure. The midterm results are excellent. As I presented, the cusp extension technique in rheumatic aortic valve involvement. There was no reop after 3-4 years, and then suddenly, as I showed to you, 15 years later, there was 25% of reoperation. This one, I believe, Ozaki has only an indication is, probably in aortic valve endocarditis, when, you don't have any other option to do if you don't have an aortic homograph, because usually, if there is a homograph bank which can provide you a homograph in the appropriate sizes, I believe the best option also is to use for this endocarditis cases presented by Stoica, the aortic homograph. If you don't have access, then do Ozaki, because the most important, as you know, I was doing in the mitral valve endocarditis with totally damaged mitral leaflets. There is no other option than to use a mitral homograph in order to avoid the use. But after 7 months, okay, you cure the infection, but after 7 months you go again to do something. I had, more than 20 cases and catastrophe. All of them, I was obliged, to reoperate on and replace either with a biological one or with a, yes. But okay, the infection was cured. Yeah.
That's very very wise strategy.
Yeah.
Do a repair with a
During
homograph
acute
tissue.
endocarditis, I don't like the use of synthetic material. For example, recently, I had an infection, a case, operated by another surgeon, to enlarge the aortic root. He did the Manukian approach, and then endocarditis, and the patch on the anterior mitral leaflet was completely broken, and there was, a hole. The patient was in acute pulmonary edema, and there was no time, to wait to cure, the infection, and I was obliged, to go. I took everything back, and then I put a homograph, reconstruct again the mitral valve with another bovine pericardial patch. And then, I accepted to have a mild to moderate central insufficiency rather than to put a ring. Okay? Do compromise in those cases. And then after, 3 weeks, he went back to Azerbaijan because he was coming from Baku. This one is important, this message, and I believe, the message to the audience will be this one. Thank you
Yes,
very
that
much.
Ozaki also can be used like bridging technique in such cases.
It's a bridge surgery. There is, for example, the use of mitral homograph in acute mitral endocarditis is a bridge surgery.
Yes.
The cusp extension is a bridge surgery for a late replacement with a mechanical prosthesis in children, in pediatric population. This one, should be a rule now. Thank you very much.
Thank you.
So I'll be extremely quick.